Well, welcome everyone. Thank you for joining our webinar today with Kristina Young and Philip Kroth, authors of the 9th edition of Schultz & Young's Healthcare USA. Kristina and Philip will be talking to us today about the Affordable Care Act, what's happening right now with the ACA, and what the future of the ACA looks like. My name is Sophie Teague, and I'm the Senior Marketing Manager for Public Health and Health Administration here at Jones & Bartlett Learning. And if you're new to Jones & Bartlett, we are a provider of instructional, assessment, and learning performance resources for the secondary, post-secondary, and professional markets. And we specialize in the areas of health and safety. Before I introduce you to our presenters, just a couple of quick housekeeping notes before we get started. First off, the presentation will last about 30 minutes, and following that, you'll have a chance to ask questions. We're expecting quite a few people today. We've got a little over 250 people registered for this session, and we've already got over 60 logged in. So we've muted all your lines. We're not going to be taking questions out loud, but you can type your question into the question box, which is in one of the panels on the right-hand side of your screen. And so you can type your question there. If you think of a question at any time during the presentation, you can go ahead and type it out there, and I will hang on to it until the Q&A piece of the webinar at the end of the session. Also want to let you know that there, if you look at the handout panel on the right-hand side of your screen as well, the slides for this webinar are available there for you to download. You can go ahead and do that at any time. And I'll also make those slides available in a follow-up email after the webinar. The entire session is also being recorded, and again, following the webinar, in that same follow-up email, I'll include a link to view the webinar. And then I'll also provide information for those of you who are interested in receiving a complimentary review copy. If you're interested in reviewing the book by Kristina Young and Philip Kroth, Schultz & Young's Healthcare USA 9th edition, I will provide information on how to request a review copy. And if I could ask Kristina and Philip if you can mute your lines, that will help to eliminate background noise.
Thank you. I'm muting.
All right. Thank you, Kristina. So let me now go ahead and introduce you to our featured presenters. Kristina Young is a clinical assistant professor emerita in the Department of Epidemiology and Environmental Health at the School of Public Health and Health Professions at the State University of New York at Buffalo. And for over 20 years at the University of Buffalo, she taught graduate courses in healthcare administration and health policy for students in the fields of public health, law, and management. Outside of academia, Kristina has held key leadership positions in a county department of health as the assistant director of an epidemiology and disease control unit and the director of maternal, child health, and family planning programs. She also has served in executive capacities for a women's health organization, 2 hospitals, a health plan, and a regional public health organization. Oh, and I apologize. Let me show you Kristina Young on screen. Philip Kroth is a professor at the University of New Mexico School of Medicine. He is also the director of the Biomedical Informatics Research Training and Scholarship Unit at the UNM Health Sciences Library and Informatics Center, and he's the section chief of clinical informatics in the UNM Department of Internal Medicine. Philip has authored over a dozen peer-reviewed publications. His research interests include adapting clinical records for research and assessing the value of various design aspects of electronic medical records. Now, before I hand the reins over to Kristina and Philip, I wanted to, or we would like to just have a quick quiz just to sort of gauge the level of knowledge of the audience of what's happening right now with the Affordable Care Act and healthcare in America. So what we're going to do, I'm going to read these quick quiz questions, and then I will launch a box in which you'll be able to answer the question either true or false, and then I'll give live results. answers. So the first question is regarding the Children's Health Insurance Program, CHIP, which is a program that provides federal safety net health insurance for approximately 9 million low-income children. Has it been it has been reauthorized by Congress for 2018 through 2020? And so you'll want to answer true or false, and I will launch the answer box here in just a moment. Okay, so there is the quick quiz question, and again, the question is about the CHIP program, a program that provides federal safety net health insurance for approximately 9 million low-income children, has been reauthorized by Congress for 2018 through 2020. True or false? And let's see, I'm looking at the results. I'm getting answers. 26 of you are saying true, 74% are saying false. And the answer is, in fact, false. I'm going to move on to the next question. The next question, a POTUS executive order from October 27 of this year would allow states to define essential benefits under the Affordable Care Act and may exclude several benefits originally included in the ACA, such as maternity care and mental health services. New rules must be written and approved prior to implementation. And let me go ahead and launch that poll. And go ahead and choose true or false. And again, the question is, a POTUS executive order from October 27 would allow states to define essential benefits under the ACA and may exclude several benefits newly included in the ACA, such as maternity care and mental health services. New rules must be written and approved prior to implementation. True or false? And we have 93% saying true and 7% false. And the answer is, in fact, true. All right, next question. The next question is about meaningful use. Meaningful use, AKA Advanced Care Information, or ACI, electronic health record technology implementation financial incentives were deleted by POTUS executive order under Macra. True or false? And I'll go ahead and launch that one as well. Oops, not that one. All right, so again, the question is meaningful use, also known as advanced care information, electronic health record technology implementation, financial incentives were deleted by a POTUS executive order under Macra. True or false? And I'm seeing a lot of people saying true, 69% saying true, 70% saying true at this point, 30% saying false. And the answer is, in fact, false. And at this point now, I'm going to close the poll and hand things over to Kristina and Philip, and we'll talk a little bit about the quick quiz. Kristina,
hi, everybody.
Philip?
This is Phil. Can you hear me?
I can hear you.
Oh, good. Okay. So I just wanted to make a few comments on the poll. First of all, most of you got most of the answers right, which is great. And then I would just make a few quick comments, and Kristina, you need to chime in here too. But with regard to the Children's Health Insurance Program, I believe it has not been reauthorized, and there are already 10 states that have run out of funding. In other words, even though they didn't reauthorize the program, they still had money left over in their accounts, and more states are running out of money, and they're starting to tell the people that were in the insurance program to look for private insurance or some other option because they're running out of money. And then, do you want to make any other comments, Kristina?
Only that just hours ago on a recent update, The Congress has authorized an extension on the federal budget for 2 weeks, and that is to prevent the government shutdown that was impending. And in that reauthorization, they included CHIP. So CHIP has 2 weeks of reauthorization at this point, which is essentially meaningless because millions of children across several states are being slated to be dropped off the rolls. The states are scrambling to try to find those funds because it's still hanging up as an uncertainty. So that token reauthorization that occurred with the extension of the federal budget for 2 weeks is essentially meaningless. So everything you said, Phil, is correct. It's still hanging out there. It's not been reauthorized. It's 20 years old, was first passed as part of the 1997 Balanced Budget Act, 1996 Balanced Budget Act, and has produced remarkable results in terms of decreasing infant mortality over the last 20 years and also material increases in childhood dental care for low-income children and vaccination rates. And so it would be a true disaster if Congress ultimately doesn't reauthorize this going forward. But we don't know.
Yes, so that's one of the things that I think has been under-discussed in the kind of milieu of the media lately, is that this is a hugely important thing to the nation's children, and the poor children, and it's just not getting a lot of attention. The only thing I'll say about the executive order is that any executive order, when they make changes to rules, there's a set process that has to be followed. They have to make changes to the law in the Federal Register. There has to be a comment period to provide feedback. Sometimes with highly controversial or changes, they get many comments. As an example, when they first implemented HIPAA, they got over 50,000 comments, and it took I heard a strange noise. Are you still hearing me? Okay.
Yes, we hear you, Phil.
Oh, good. Okay, I just heard a weird noise on my phone. Anyway, and so they actually pushed back the implementation date because they needed more time just to process all the comments, and then they have to roll it out. So these things don't happen overnight, and they do take many months or sometimes even years to change. And then the last thing, as kind of a segue into the first slide for our presentation, is that with regard to meaningful use, which has been subsumed under MACRA, which we're going to talk about next, you can go to the next slide there, Sophie. That meaningful use, which they've renamed under MACRA as it's been subsumed to Advancing Care Information, was a bipartisan effort, and because of that, it went through sort of what John McCain recently called the regular order, in that, you know, it had debate and both parties got input and they agreed that they wanted to do this. And because of that, both the President and Congress has been pretty much silent on MACRA, which essentially means that the implementation is going to continue. All right, so starting the presentation there, this was passed in 2005, and it was really designed to complement or build upon the ACA as it was passed in 2010. Just reviewing the major features, the idea is to promote value over volume-based care, or at least to incorporate a significant portion of the reimbursement tied to the value that's delivered to the patient. It expands, ACA major feature, it expands coverage and costs. It set up the health insurance exchanges and gave the states the option to receive what's called Medicaid expansion, which is additional federal funding for Medicaid to provide additional supplements to low-income people for buying insurance on the exchanges. And it basically defined a sort of standard for what they considered to be baseline insurance. So it includes things like maternity care and mental health care, minimal levels of coverage, so you couldn't basically sell quote-unquote junk insurance that left out huge portions of healthcare. It's designed to promote population health and prevention and to focus on that. And the idea is to incentivize care coordination across various domains of healthcare, from the hospital to the hospital to a nursing home or rehab, et cetera. MACRA, which, by the way, stands for Medicare Access and CHIP Reauthorization Act, it is, again, to provide value over volume-based care. But what they really want to do is they want to essentially incentivize providers of healthcare to meet certain quality targets. And if they do that, the people that do that the best will get a rate increase on their reimbursement under CMS 2 years after, or 2-year delay, and then that's basically funded by the folks that don't achieve the highest quality and get penalized and actually receive less. So the people that provide better quality get a bigger slice of the pie than the people that didn't get as much quality as the people that won. So the losers pay the winners is kind of a crude way of saying that. There's basically different approaches to this. Most healthcare organizations are participating in what's called MIPS, or Merit-Based Incentive Payment System, which is essentially a set of reporting requirements where you have to report standardized quality reporting metrics to the government, and they essentially will, you report these, and then it takes a year for the government to kind of sift through them all and then identify the winners and the losers, or the people that do better versus worse, and then for the following fiscal year, they make adjustments to your payment rates for Medicare based on that quality outcome. If you don't participate in MIPS, which is the vast majority of people, there are these alternative payment models where the idea is to set up accountable care organizations, which are essentially organizations that are there's more coordination of care, so systems that include nursing homes, hospitals, outpatient care, and then provide their own internally driven quality improvement processes to improve the quality of care and reduce cost. There's a different set of rules for those folks than for the merit-based incentive program participators. Unfortunately, there aren't enough alternative payment models, or ACOs, in existence yet for most healthcare systems to join. So it's somewhat of a funded experiment or alternative to the MIPS system. They want to see what works better. As you know, the CHIP reauthorization ran out in 2017, but at the time they passed it for CHIP for 2 more years under the MACRA legislation. And the idea is it shifts fee-for-service for everybody to APM incentive models by 2018. This is under the APM. So you get paid basically a capitated rate per patient, and then whatever organization makes that agreement, in the ACM, they pay that amount under the alternative payment model. The MIPS people, they get the standard fee-for-service, but they're either rewarded or penalized how they did 2 years ago. It is a bit confusing, and there's a lot of criticism of this in the fact that the losers pay the winners, in the sense of if you are say an organization that does a lot of uncompensated care, provides a great value to the community, you may not have as many resources to do all the quality improvement that you need. You will be penalized, and arguably those people would benefit from more funding. Sort of like this is a criticism of when this sort of thing is done with public education, where you have schools that are failing or getting poor test scores. If you financially penalize the failing schools, it makes it even arguably harder for them to kind of dig out of the hole. That's one of the criticisms. Another big criticism of MACRA is the fact that there's a delay of 2 years. It's very complicated. There's many measures. There's an estimate out there that it's going to cost all the healthcare organizations outside the government about $15 billion just to collect all the data that they need to require under MACRA. Next slide, please. I went over some, whoops, yeah. Let's see, where did I go? Oh, go back one. I think you went one too many there. It should say, oh, wait, where are we here? No, that's right.
No, we're on the right slide.
Okay.
This is just a summary. Yeah.
So again, pays for value, not volume, rewards, cost savings, and quality. It does standardize several reporting systems, and as an example, one previous reporting system would have smoking, yes or no. Another one had, recently quit smoking, quit more than 6 months ago, that sort of thing. So it standardized all these sort of reports so everyone reports the same thing and in the same variable in the same way. It subsumed meaningful use, which is now called advancing care information, and we talked about MIPS versus APM. Next slide, please. Okay, there we go. It also included the doc fix, which was sort of the year-by-year funding that Congress was putting on Medicare reimbursement rates, the difference between what doctors were receiving versus the old previous funding. They were getting quite far behind because they kept adding more every year, and every year this created a lot of confusion because no one knew if they didn't authorize the doc fix, then the care compensation would drop like by 30% because they were so far behind. MIPS composite score, there's essentially 4 domains to make up your final score: quality, resource use, clinical practice improvement activities, and the advancing care information or meaningful use of health information technology. Next slide. Next slide. There we go. And APMs are a little different. They're not subject to the MIPS adjustments. I already talked about this a little bit. There's an annual lump sum payment based on 5% of the previous year's estimated aggregate expenditures according to a fee schedule. And the nice thing for individual physicians, if you work for an APM, they don't really collect data on you individually. It's sort of on the whole accountable care organization. Next. And then Macra today, this was as of November 10th. The doc fix, I don't know why we didn't update this slide from the last time, but the doc fix has been implemented, and we're still waiting to hear about CHIP. Next slide. ACA components requiring legislation to change. So they've been trying to, up to this point, they've been trying to make changes to the, Kristina is going to take over at this point. I'll let you do this slide, Kristina.
Okay, sure.
You know,
as everyone who's listening knows, the past many months have seen numerous attempts to do some manner of repeal of the ACA, otherwise known as Obamacare, and as you're aware, none of those congressional efforts have succeeded. It's important, I think, as an overall understanding to realize that the Affordable Care Act is a law, and there are several components in that law that require legislation to change. Executive orders can't change anything in the ACA law, and these are just some examples: family coverage for children up to 26, banning insurance denials for pre-existing conditions, changing the baseline 10 essential benefits. We'll talk more about that a little bit later. Reinstating an annual dollar limits for covered benefits, and reinstating co-pays for preventive services. So again, keep in mind that the ACA is the law of the land, and that executive orders, which the President and the administration have attempted to implement, which Phil talked about earlier, those executive orders are rule changing. They're not law changing, and they require many months to write up modifications and then go to publication, public exposure, hearings, etc. So none of these things have changed in the law at this point. Okay, next slide. I think many of you are also aware that the current administration is not supportive of the Affordable Care Act, and in that regard, it has made some significant efforts to unravel the Affordable Care Act. The administration cut the advertisement and public media budget for the open enrollment period by 90%, essentially deleted it. They also shortened the enrollment period from 3 months to 6 weeks. So previously it began early November, ran through the end of January. Now for enrollment in the states that have federal exchanges, that enrollment period is now only 6 weeks, November 1st through December 15th. Also, the Affordable Care Act previously had funding to support what were called navigators, people who were assisting individuals with their enrollment process, and that navigator's budget was slashed by over 40% as well. Okay, next slide. All right, so, and I think it's important to note also for our listeners and participants that Phil and I dated these slides because there are so many activities underway in the current administration to do whatever they can to unravel or make the Affordable Care Act appear to be unsuccessful, that these developments just occur very rapidly. So we dated these slides to give people a sense of this rapid fire kinds of attempts to undo the ACA. On October 12th, the President issued an executive order that rescinded funding for cost-sharing reduction subsidies, or CSRs, for the insurers of low-income consumers. Again, this was a provision in the Affordable Care Act that provided federal funds to help underwrite the costs of providing low-cost health insurance premiums to people of lower income. It also released what are called association health plans from Affordable Care Act regulations on lifetime benefit caps and essential services. Association health plans are ones that are group health plans for example, people in specific professions, or for people, for example, who are small business owners. These are called association health plans. And it essentially took off the ACA regulations to help ensure that those were high-quality plans. That executive order lifted that assurance for quality. Those association health plans typically enroll mostly healthy individuals, and they have the effect of moving more high-risk people to state-subsidized plans, thereby increasing the severity of the risk pool and causing increases in premiums. Generally, the association health plans released from the ACA regs was not considered a sound idea by people in the insurance industry. Next slide. Okay, on October 18th, the President also issued another executive order. In response to that executive order on the 17th of October, 18 states' attorney generals and the District of Columbia filed a brief in California versus Trump to seek a preliminary order to prevent the rescindment of the CSRs. Approximately a week later, a U.S. District Court judge denied the request for the preliminary order. The bottom line on this situation is that many insurers had anticipated an executive order of this type and built added costs into their premiums for 2018. So they were anticipating a move by the administration to cut off those CSRs. Rescinding the CSRs actually has very little effect because impacted consumers will, by the fact that they're losing the subsidy for their health insurance, actually receive a higher level of tax credits under the Affordable Care Act. It's estimated by the Congressional Budget Office that defunding the CSRs will cost the federal government approximately $200 billion over 10 years. Next slide. Okay, again, a reminder that executive order implementation takes at least many months. New rules have to be formulated. Those rules then are required under law to be published in the Federal Register and also be subjected to a period of public comment, which Phil alluded to earlier. And depending on the nature of the particular rule or rules, there can be enormous numbers of comments, which then folks at the Department of Health and Human Services have to sort out and aggregate and determine impact of. Then the rules have to be compiled along with deliberation on public comments, and then the final rules are issued, and then an implementation process begins. So in our democracy, this is not a swift endeavor by any estimate. Okay, next slide. As an example of rulemaking, the CMS, the Centers for Medicare and Medicaid Services, has reinterpreted the ACA, the Affordable Care Act, essential benefits requirement. This was on October 27th. The proposed rules allow states to define essential benefits. And again, this is a provision of the law which the administration would be hoping to alter with the executive order. Essential benefit benchmarks can be derived. The executive order gives states to derive their essential benefits benchmarks from any typical employer plan, in quotes, because nobody really knows what that is, with 5,000 plus employees. And the benchmarks may not be more generous than a state currently offers. For example, states can select plans that exclude maternity care, mental health care, care for HIV/AIDS, emergency services, and drug coverage. There are some legal opinions that are suggesting that this state role in setting their own benefits may actually be illegal because the law mandated 10 essential benefits, and there are many questions about whether it's legal to transfer this authority to states because the law, again, this federal law, the law of the land, mandates the 10 essential benefits. Proposed rule comments were due on November 27th, and to date I've researched this and I haven't seen any summary of those comments. And my belief is that Department of Health and Human Services is probably buried under a mountain of comments and are presently trying to sort those things out. Okay. All right, the Alexander Murray Bipartisan Healthcare Stabilization Act of 2017, nice, short, neat title, was a proposal by a Republican and a Democratic senator to stabilize the insurance markets. They're suggesting a 2-year extended funding of the cost-sharing reduction subsidies that were to be overturned by the President's executive order. They wish to restore the ACA enrollment outreach funds, which is now a moot point because the enrollment period is coming to an end in approximately a week. To expedite state waivers for premium subsidies that is states applying to the federal government for assistance with funding for individuals of low income to assist with their premium payments, and to enforce the individual mandate and shared responsibility for employers of 50 or more employees. So again, the rapid nature of what's going on, we're already almost at the end of the enrollment period, so some of this content of the bill is not even relevant any longer. However, there's a bit of an update that I'll mention later on where this Alexander Murray bipartisan health bill is. Okay, next slide.
Kristina, I just want to make a quick comment on that last slide, if you go back quickly.
Sure.
Is that this is Lamar Alexander, and I forget her first name, Murray, the Senator Murray's the Democrat. They're the co-chairs of the Health Committee, the Health, Education, Labor, and Pensions Committee in the Senate. And this committee, and this is what John McCain was referring to when he was talking about regular order, where he was saying how you know, there should be, when you have a bill, you have committee hearings, and they started to do this. I think they each called, the Republicans called like 5 experts, and the Democrats called 4, and they had deliberation and discussion, and then they came up with this proposal. And you know, the latest bill, the tax reform bill, this never occurred anywhere in the Senate. This was all just kind of thrown together in the back room very quickly, even with, I don't know if you saw the pictures on TV where they're handwriting it in the margins of the document. But this is what a lot of people are criticizing about the current process with the tax bill that contains some proposed healthcare funding changes as well, in that they're not following the regular order in coming up with this, which allows debate, expert testimony, and whatnot. And this is a good example because both, and one of the tremendous benefits you get when you do this is that both parties form a certain amount of consensus, which is good. And I cite again the Macra bill, which was developed in a bipartisan manner, is basically not being touched. But the ACA, which was, again, even though they did follow regular order, the Democrats sort of strong-armed it in a little. At least that's what they've been criticized for doing, and because of that, there's a lot of angst. And this is really an excellent example of when you actually get the Senate or the Congress to function as it's supposed to, you tend to get better outcomes that are longer lasting. But I thought this was really important to mention this because if you hear Lamar Alexander or Senator Murray talking about this, they're very positive about just this. I think they did this over the period of just a few weeks, and then the Republican majority leader told them to stop the hearings. If I got that right, Kristina.
Yes. Yep. And Alexander Murray is still out there. We can talk about that in a minute when we just give an update on the current federal tax bill. So alongside the Alexander Murray Act proposal, there's been a great deal of public confusion due to the anti-ACA rhetoric. The president's statements such as Obamacare is finished, it's gone, it's no longer, you shouldn't even mention it. Well, it isn't. And however, Americans exist on sound bites. And so one really needs to wonder how many people in the general population who would be affected by provisions of the Affordable Care Act, when they hear the president say it's gone, it's dead, it doesn't exist anymore, if they really believe that's the case, which of course is not true. Important also to keep in mind that about 10 million citizens, American citizens, are enrolled in the ACA marketplaces. And that does only represent, although it's a significant number, a tiny fraction of the about 250 million people who get their health insurance from employers, from Medicare and Medicaid. So while the ACA Act is extremely significant and affects the lives of 10 million or more people, it is only a tiny fraction of most people who get their health insurance from other sources. Okay. Next slide. All right, so the Congressional Budget Office, which is a nonpartisan analytical entity which does analyses of all things that have to do with laws and their fiscal implications, assessed that there would be no significant federal budget effect from the Alexander Murray Act. It, in fact, would reduce the federal deficit by about $3.8 billion between 2018 and 2027. The CSR's termination cost of $194 billion had already been included in the budget as a baseline of funded entitlement. So this was not something that needed to be included in the new budgeting process. There would be no material changes in the numbers of insured, and user fees fund the Department of Health and Human Services 2018-19 outreach and enrollment activity. It would have a small overall effect on state, local, and tribal governments. So the bottom line on Alexander Murray is that it would postpone deleting those cost-sharing subsidies from the federal government to insurance entities, and it would have essentially neutral effects on the numbers of individuals enrolled in under the ACA. Okay, next slide. Okay, the individual mandate, and that is the requirement for essentially all Americans with few exceptions to obtain health insurance coverage under the ACA or pay a penalty, has now been introduced into the Senate's tax bill, the Senate's form of the tax bill. On October 30th, Senate Republican leaders included the repeal of the individual mandate. On November 8th, the CBO, the Congressional Budget Office, estimated that would result in about $338 billion in savings. However, they also estimated that as a result of that repeal, about 13 million Americans would lose their health insurance. In early December, the CBO issued another estimated 10-year savings of $416 billion. However, 15 million Americans would lose their health insurance. Okay. The Affordable Care Act today, some facts about how things are currently going in spite of all this background noise with new rules proposed and so on. The ACA Medicaid expansion and consumer protections are popular among Americans according to many different poll sources and working well. Costs for about 155 million Americans with employer-sponsored health insurance rose only 3% in 2017. the continuous political rhetoric about how the Affordable Care Act is driving up by enormous increments the cost of health insurance for Americans simply is not true. And, you know, as politicians who are anti-Affordable Care Act spout the rhetoric, they tend to lump numerous effects that have to do, for example, only with the ACA as like an overall national catastrophe. And this just isn't simply true. It is true that in some markets where health insurers have pulled out and individuals have few choices, that is little competition for their Affordable Care Act coverage, that premiums have risen. There's no question about that. And some of them have risen precipitously, but that is not the case overall. On November 7th, the state of Maine overwhelmingly approved a referendum adopting the Affordable Care Act Medicaid expansion. This was significant because the state is led by a very strongly Republican supporter of the President administration. The people of Maine actually created a referendum that individuals voted on their election day, and overwhelmingly, by a margin of 3-1, or I believe it may have even been higher than that, approved Medicaid expansion in their state. And their governor is trying to figure out how to stop the implementation, but we don't know the outcome of that so far, and likely he won't be successful. As of November 15th, with 2 weeks of open enrollment for the Affordable Care Act underway, the totals increased 40+% over the same period in 2016. Now, there's a recent update on that. When I checked just within the last 24 hours, the enrollment has slowed somewhat since this early surge of the open enrollment period, and there are some analysts who are suggesting that at this point it appears that the enrollment in the Affordable Care Act insurance marketplaces will be down about 20% below what they were for 2017 based on the 2016 enrollment period. However, we definitely won't know what those overall enrollment figures are likely until mid-February, because there are some, even though the federal exchanges are closing down by December 15th, there are several states that run their own exchanges, and those are going to continue to be open through most, if not all, of January. So the jury is still out about what enrollment's going to look like for 18, but given the administration's attempts to stymie enrollment by slashing media funds, advertisement, slashing funds for navigators, it doesn't appear to have the devastating effect that they had intended. Next slide. So what are some of the bottom lines on the ACA going forward? Again, legislative change requires congressional action on extremely complex issues. They've had numerous, as we all know, failed attempts to vote repeal and replace, and that illustrates the difficulty. Another difficulty embedded in this is that no one has come up with anything that would be considered a substantive replacement for Obamacare. They keep talking repeal and replace, but the replace is very thin. The individual mandate repeal through the tax bill would be the first change to the ACA law. So again, those executive order rules are pending, need to be written and deliberated and so on. The individual mandate repeal, if that were to pass in a tax bill, would be the first change to the actual law. That early open enrollment surge suggests popular support with political implications. Even though the enrollment has fallen off somewhat, there's still a tremendous amount of discussion about senators who are going to vote for a tax bill that repeals the individual mandate and may have other implications for the Affordable Care Act down the road. May get some politicians looking over their shoulder and wondering if their constituents are going to be unhappy, which, of course, for a politician is not a good day. Macra continues, as Philip mentioned several times, strong bipartisan support for continued push towards value and quality. It's likely to survive in its present form, with the exception of the unthinkable lack of reauthorization for the Children's Health Insurance Program. There are many people who believe that there's nobody in Congress who would like to be branded with pulling health insurance from between 9 and 11 million low-income children. But time will tell.
Yeah, I think maybe we should just pause a second and also just say that with regard to the tax bill, which is where this critical component of the ACA lies, the individual mandate, and that actually helps keep costs down because it keeps people in insurance. It keeps getting the care that they need earlier on than they would if they didn't have insurance, and tend to wait until things progress longer. Right now, there were two different versions of that bill passed in the House and the Senate with great fanfare in the media. Now those two bills go to a reconciliation committee where representatives from the House and the Senate hammer through the differences in the two bills. Many bills have gone to this committee and died because they were unable to reconcile the differences. What happened with the Affordable Care Act is the Democratic version in the House went to that committee along with the Senate version, and then because of expediency, and this is what I was alluding to before, what the Republicans didn't like is then the Democrats sort of made the decision, let's just pass the House bill, and they got the Senate to agree to just pass the House bill, and then it went right to the president's desk, rather than spending more time trying to work out the differences. I just want to underscore that spending that time to work out the differences really does matter, in that bills that seem to pass when that's done then get support afterwards, and you don't have this constant attacking the bill after it was passed or trying to go back to what we had before. So if they do manage to hammer out a compromise, then the bill has to go back to the House and the Senate, and they have to have another vote in each case, and then every senator and House member has to determine if they want to support the compromise bill. So the repeal of the individual mandate is in no way finalized, and so pay attention to the news about the negotiation between the House and the Senate, and then we'll see what happens. They do come up with something, if that's still in the bill, that goes back to the House and the Senate, and then again, if members of the House and Senate will vote on the reconciled bill. Did that make sense to you, Kristina?
Yeah, that's great. What they're engaged in right now is a very complex, huge process where there are all kinds of promises being made and trade-offs being made and deals being made, and there's another bombshell that has not yet received media attention worthy of its significance. And that is that while I'm sure many of our participants have heard people railing about how this tax bill is going to increase the deficit, and the people who support the tax bill say, no, the corporate tax cuts are going to help companies create many more jobs, they're going to fuel the economy, et cetera, et cetera, et cetera, and that's all going to be good for the deficit and deficit reduction. In these bills, there is an assumption that the deficit that's created by them will, it's actually part of the proposed law, will result in triggering $25 billion in automatic cuts to Medicare starting next year. And that is underscored in a Congressional Budget Office report on the tax bill, on the tax bills, both forms of them. So triggering a $25 billion automatic cut to Medicare starting next year is going to create enormous problems down the road as 10,000 Americans hit Medicare eligibility every single day. So the backstop on the deficit is cutting Medicare, and likely Medicaid will be next. So this tax bill has enormous implications for the healthcare delivery system, in addition to the repeal of the individual mandate if this goes through. It's not pretty.
Yeah, and I would just say that this is happening at a time when we're really approaching a crisis, where not only is there a shortage of providers that's getting worse and worse, but the chronicity of illness is increasing, and the proportion of the population that's old is actually increasing, and the proportion of the population, because of modern science, that have multiple chronic medical problems is increasing. These are the highest utilizers of the medical system. And, you know, this is all happening at a time when I think the last time CMS increased the number of slots or funded slots for residency programs was in 1996 or somewhere in the mid-90s. And this is the year where the number of medical school seats in the United States is now greater than the number of residency slots we have. Now, most educational programs, as an example, in medical schools are primarily funded by states because states are interested in producing doctors for their regional needs. Residencies have been, most of them, not all of them, but the vast majority of them are funded by CMS. That's funded by Congress. And to fix this problem, at a time when this the doctor shortage is continuing to get worse and worse, is going to require Congress to act to increase the number of funded residency slots. And I would just say, given what I've seen in the past 6 months or so, I would bet a mortgage payment that this Congress is not going to increase the number of residency slots anytime soon. And so at a time when the population is aging, we have more patients with multiple chronic medical problems, we're going to be graduating medical students that will not be able to do a residency in the United States. As a backdrop against all that's happening right now. So all I can say is we live in very interesting times.
It's an underestimation.
Okay. So, Sophie, do you want to talk about the teaching resources, or do you want to the question?
Yep.
We'll take the next slide, and just as a summary, the ACA and Macra future prospects. Macra is going on as planned. The CHIP reauthorization, as we've beat to death here, still awaits congressional action. There are no changes to the ACA existing law to date. Repeal of the individual mandate would be the first one, if that in fact comes about. The tactics to impede the ACA enrollment appear largely unsuccessful to date. There are no effects of the executive order on CSRs to date as well, and the Alexander Murray bill awaits uncertain congressional action. And we're sure, based on sort of the insider reports of what's going on in Congress, that the Alexander Murray bill, what's left of it that's relevant, is going to continue to be part of the negotiation between the Senate and the House. The Senate and the House versions of the tax bill. So this is really a message for all of you, and particularly those of you with whom I empathize greatly, who may be in the classroom trying to teach students about this, to stay tuned.
Great, thank you, Kristina. And at this point, we're going to move into, and thank you, Philip, too, for both of you for your fantastic presentation. At this point, we're going to move into the question and answer segment of the webinar. Just to remind you, if you want to ask a question, you can use the panel on the right-hand side of your screen that says questions. Simply type in your question, and I will read it out loud to Kristina and Philip. Before we move over to questions, I just want to quickly say that if you are interested in receiving, well, first off, the teaching resources for both instructors and students, Kristina and Philip have kindly included a bunch of links here, and these are included in the handout that you can download, again, on the right-hand side of your screen, but they will give you access to a lot of resources that you can use to stay current on what's happening with the Affordable Care Act. I also want to mention, before we go over to the Q&A piece, that if you'd like to evaluate Kristina and Philip's book, Stoltz and Young's Healthcare USA, 9th edition, this just published earlier this year, this past spring, and complimentary review copies are available for instructors. Simply go to this URL, go.jblearning.com/healthcareusa, and that'll take you right to a page where you can download a complimentary instructor review copy. You can get sample chapters, and you can also request access to instructor materials. So at this point, I will move into the question and answer section of the webinar. Where did my question box go? And we do have a few questions coming up on screen here. First off, in thinking about the POTUS executive order from October 12, which rescinds federal funding for cost-sharing reduction subsidies for low-income consumers, what effect might this have on high-risk medical consumers' choices about health plans?
This is Kristina. Excuse me. It's clear that the overarching effect of that order rescinding the cost-sharing reduction subsidies will be to move more high-risk medical consumers to the state-subsidized health plan. And so, again, it'll have the effect of increasing the intensity of medical needs and therefore costs to the state health plans. So that is the largest overriding concern about rescinding the funding.
Thank you, Kristina. Another question coming through here. Given this year's reduction in the ACA enrollment period, reduced enrollment assistance, and reduced media advertising, what impact will these tactics have on 2018 enrollment, or what have they had on 2018 enrollments to date?
Well, it's Kristina. You know, it's interesting to note that the beginning of the enrollment period saw a remarkable surge over the enrollment period in 2016 for the 2017 funding or insurance subsidies. It appeared initially, and this may still be the case to some extent, that the current administration's efforts to unravel the Affordable Care Act and all the media attention that received, there are many experts who speculate that people perceiving that something they had previously through the ACA was going to go away actually caused this enormous surge in enrollment during the first couple weeks of the open enrollment period. So now, as we're approaching the end of that open enrollment period, which ends, I believe, a week from today on the 15th of December, enrollment is still very robust, and it's unclear whether the tactics of the administration to discourage people from enrolling in the provisions of the ACA has had any impact at all, and it may actually have had the opposite effect. So time will tell. It'll probably be the middle of February before we actually are able to compare enrollment figures from 16 with enrollment figures for 17.
Great, thank you. Have a few more questions coming through, and again, just as a reminder, if you'd like to ask a question, you can use the question panel on the right-hand side of your screen. Just type in your question and I'll read it out loud. Let's see, we have one person, we've got several questions. One goes back to, I think, the original quick quiz that we did at the beginning of the webinar. Wasn't CHIP originally financed by the states? No.
CHIP actually provided federal funds under the Balanced Budget Act of 1997, 20 years ago, provided additional federal funds to encourage enrollment of low-income children by subsidizing at increased levels the state share of Medicaid. Remember that CHIP is a Medicaid authorized program, and so states, based on their per capita income, receive varying levels of federal matching support for their child health insurance program to enable expanding enrollment to more and more children. So no, it was a federal initiative authorized under the Balanced Budget Act, which increased support or federal subsidy to states for their matching dollars for children on Medicaid.
Great, thank you, Kristina. Here's another question. Go ahead, Philip, did you have something to add? Okay. One more question here. Any idea if the Maine referendum would open Medicaid for all state citizens or expand income limits?
I'm not familiar enough with the details of the Maine referendum to be able to authoritatively answer that question, although it is my belief that the Medicaid expansion referendum in Maine would follow the same income guidelines as the other federal Medicaid expansions, because those guidelines Maine would be required to meet in order to qualify for the federal subsidies. So my belief is it would mirror the Medicaid expansion parameters in terms of income requirements that have been put in place in other states.
Great, thank you, Kristina. Here's another question. What has been the general impact on hospitals as the ACA has been implemented?
The overall impact, and Phil, jump in here. The overall impact, the overall impact, the most notable one, has been that the Medicaid expansion has actually significantly reduced the level of uncompensated, that is unpaid for, or uninsured care in hospitals across the country. So hospitals generally have done better under the ACA given the Medicaid expansion. It is covering the cost of services for many, many previously uninsured individuals. The other dimension to that, and this is important to keep in mind if the administration begins to reduce Medicaid subsidies, as part of the Affordable Care Act, a provision called DSH, Disproportionate Share Hospital, funded by the federal government to help hospitals subsidize the cost of their uncompensated care. Under the existing law, that disproportionate share hospital applies very significantly to hospitals, serves large numbers of low-income individuals, was scheduled to be reduced, and those reductions are currently taking place. If, in fact, there are cuts to Medicaid or anything is done deleteriously to the Medicaid expansion, there would have to be a reversal of that disproportionate share provision, because hospitals would then be required to absorb higher portions of that uncompensated care. So overall, hospitals have benefited significantly from bringing large numbers of individuals into the Medicaid ranks.
Yeah, I would just add too, the other thing that's happened with the ACA and Macra. In Macra, it is it's made an attempt to standardize the metrics that hospitals had already been reporting through PQRS and other quality reporting requirements. However, Macra has actually increased under the score the total number of things that they have to report. So again, the amount of money that the country, the non-funded hospital industry, if you will, is spending per year to collect the additional data as required under Medicare is estimated to be about $15 billion a year. That's roughly what CMS, the budget to fund all of the residency programs in the United States is. So, like Kristina is exactly right, that the proportion of uncompensated care that hospitals have had to eat in the past has decreased. The data reporting requirements has significantly increased. And the data reporting requirements have forced hospitals to buy more advanced health IT so that they can collect. They've had to make fairly significant process changes in the way their inpatient and outpatient centers function. A lot of the data that's requested by Macra, as an example, may not even be collected in a sort of in an EHR, an electronic health record that a hospital has up and running, and so they have to then work with their vendor to figure out to add in the data that in the form that it needs to be collected, and then figure out sort of process-wise where in the hospital these things happen. So as an example, if a patient comes in and the only time they see or interact with the hospital system is to go to their eye exam, which is true for a lot of young healthy people, do you have to ask the ophthalmology clinic to assess smoking status and put that in the chart? Or ask or to screen for obesity. I know my wife would be somewhat offended if she went in to get her eye exam and someone handed her a pamphlet about obesity. She would not. That would be a negative patient experience. But yet, hospital systems are facing these kinds of process changes because they need to get complete data sets and to report this data because they're worried about losing reimbursement 2 years down the road.
Great, thank you both, Kristina and Philip, for that, for those answers. I see that we're running a little bit over time. We're at 3:06. I do have 2 more questions here, great questions, which for those of you who can stay a little bit longer, we'll go ahead and ask those last 2 questions. But I would just remind you that if you are interested in reviewing Healthcare USA, go ahead to the link on screen and you can request a complimentary review copy. I would also say that if you don't have time to stick around, you have further questions that you'd like to ask, feel free to email me directly and I can communicate with Phil and Kristina. And then also that we will be posting a recording of the entire webinar on the, we have a new faculty lounge for public health and health administration instructors, and you can go to that lounge and join at go.jblearning.com/PHLinkedIn. So with that, I'll go ahead and ask the last 2 questions here for Kristina and Philip. Are hospitals receiving disproportionate share payments? I thought these payments were eliminated under ACA.
No, the hospitals are still receiving disproportionate share payments. There's a process under the ACA in which they're going to be, and they're in the process of being phased out. So hospitals are still receiving disproportionate share at this point in time. I'm not sure what the final date is for that phase-out period, but they weren't cut off totally from the outset, no.
Great, thanks, Kristina. And one last question, is there any feedback yet on Macra and the effect of quality care in the U.S.?
Feedback, I guess, right now they're still, this is the first year that you have to report 3 months worth of data that's going to have an effect in 2 years. So this is in the previous year, it was sort of practice where you were sort of submitting data and getting feedback on your data. But this year, what we report this federal fiscal year, and I think the minimum you do is you pick the 3 months out of the year that you want to report on, or you can report the full year. This is the first year that you're going to start to receive a penalty in 2 years if you end up being one of the losers as opposed to one of the winners. And again, I'll just reiterate that the losers fund the winners, and there's, they kind of grade on a curve. So first they get everybody's data, and then they kind of rank everybody in order, and they say, okay, the top X% are going to get the bonus, and that's going to be paid for the bottom Y%. And that's where we are right now. So hospitals are really in a vice right now, rapidly trying to change multiple processes in their inpatient, outpatient clinics, getting their IT working, getting their reporting working, getting their physicians and mid-levels and nurses to enter in new kinds of data in new venues to meet this deadline this year, because if they don't, they're going to start losing money in a couple of years.
I'd like to just, in regard to the disproportionate share, I just pulled off my bookshelf my copy of Healthcare USA, and just more specifically, in 2015, the federal allotment to states for disproportionate share was $11.9 billion. And as I mentioned earlier, under the assumption that the ACA would significantly decrease the number of uninsured people, the law originally called for reductions in the disproportionate share state allotments between 2014 and 2020. That's the phase-in that I referred to. However, the start of the reductions has now been delayed until 2018, which is suggesting that also they'll be continued through 2025. So they were not cut off as a result of the ACA, and in fact, over $11 billion was paid in 2015. So just a little bit more clarification on that.
Great, thank you, Kristina. All right, well, that was the last question. Thank you both, Philip and Kristina, for your fantastic presentation, and thanks to everyone today for joining the webinar and your thoughtful questions. Again, as a reminder, if you have further questions, feel free to reach out to me directly at steag@jblearning.com. And again, you can continue the discussion over on our faculty lounge group on LinkedIn at go.jblearning.com/PHLinkedIn. You just have to request to join, but we can absolutely continue the conversation there. And as soon as the recording is ready, it will be posted there. So with that, I'm going to go ahead and close out our webinar. Thank you, everyone.
Thank you, Sophie.
Thank you.